Courtney, you can introduce yourself. Courtney Campbell from The Ohio State University.
Yes, thank you, Dr. Caselli. So, my name is Courtney Campbell. I'm a fellow in cardiology at The Ohio State, and just want to thank you all for inviting me to help lead this journal club discussion. And I chose this paper from 2017 on clonal hematopoiesis and risk of atherosclerotic cardiovascular disease, in part because it seems the idea of CHIP and clonal hematopoiesis is talked about a lot in the hematology world, but not as much in the cardiology world. And I've invited two experts from The Ohio State to help comment and lead some of the discussion. First, Dr. Daniel Addison. He is co-director of our Cardio-Oncology program and a cardiologist. And then Dr. Tamana Hook, who is an assistant professor here in hematology and an expert in clonal hematopoiesis, and it's an area of her research. So thank you guys both for joining. And as I go through the paper, first we'll have some pre-questions. I will go through the paper and kind of at the end of each section give a chance for Dr. Addison and Dr. Hook to weigh in, and then at the end we'll go through post questions and then have time for discussion kind of more broadly on CHIP and how that relays into clinical practice for cardio-oncology. So let's see. All right. So first, no disclosures as required to say. So for the pre-questions, and I don't have audience response, so we'll just talk through them. So the first question, the most common mutations detected in clonal hematopoiesis of indeterminate potential, or CHIP as I'll refer to it, affect genes that regulate hematopoietic cell inflammation, proliferation, transcription, or apoptosis. The proposed mechanism by which CHIP may increase the risk of developing coronary artery disease is through the cholesterol, increased inflammation, increased thrombosis, or increased endothelial damage. And last two questions. People found to have CHIP are most at risk to develop a myelodysplastic syndrome, amyloidosis, an acute leukemia, or a low-grade lymphoma like CLL. And then last, CHIP is detected by peripheral blood testing using quantitative PCR, flow cytometry, FISH, or next-gen sequencing. So hopefully, at the very least, you come away with some of these points by the end of this talk. All right, so here is the paper from New England Journal. It's by Dr. Jess Wall and from a group at Harvard Broad Brigham and Women's from Dr. Ebert. Okay, so some background. CHIP is referring to the expansion of hematopoietic clones carrying a recurrent somatic mutation. So these aren't inherited mutations, it's ones that are picked up over time. The most common ones are in these three kind of alphabet soup, DMT, TET2, and ASXL1. These are all loss of function, and these are what they stand for here. The main things to take, though, is it's DNA methyltransferase, a TET methylcysteine, and then transcription. So these all have to do with epigenetic alterations. So the addition of methyl groups tend to, in very broad sweeps, hide the DNA, so they are less expressed, not transcribed. So by loss of function of these, it's allowing the targeted genes to be available for transcription, so activating generally. And then one other CHIP is a specific mutation in JAK2 that's an activating mutation. And sorry. And then these lead to apoptosis, decreasing apoptosis, and increasing proliferation. So altogether, these mutations give a selective advantage. They're activating, they are more likely to proliferate compared to other stem cells, and they are still retain the ability to differentiate into mature cells like granulocytes, monocytes, or lymphocytes. And they are detectable in the peripheral blood. All right. So this is one illustration on how CHIP might work. So you have the general clone size stem cells, and then this purple represents just an unrelated mutation. The red represents a potential CHIP mutation that gives a selective advantage, so it increases the percentage in the population. If someone happens to get a disease-causing mutation, you see they can develop MDS, and then another hit and a mutation can lead to AML. None of these are a very small percentage actually end up with something like AML, but you do see increases in these populations. So last background slide, CHIP was most common in myelodysplastic syndrome and acute myeloid leukemia. That's where these were first noticed. And the paper that predates this is a New England Journal paper from the same group in 2014. And what they did is they looked at whole exome sequencing of over 17,000 people, didn't have any known weren't selected for blood cancer, but they did look at genes that were linked to blood cancers for any kind of changes, variants, insertions, or deletions. So looking for these CHIPs. So broad population of mutations that they've seen in known cancers. And this is where they identified these groups, DNMT3A, TET2, ASXL1 were very common, and then much less common but still present is the JAK2. Very rare in people under the age of 40, but pretty common in those over the age of 70, over 10%, and almost 20% in those over the age of 80. And it does confer an increased risk of hematologic cancer. And what they were surprised in this paper was that it was also associated with an increased risk of coronary artery disease and ischemic stroke. So that finding really spurred their hypothesis that led to the paper we're discussing, that these CHIP mutations could be causally linked to atherosclerosis and cardiovascular disease. So before I start into the paper itself, see if Dr. Addison or Hook have any comments on the background or anything they want to add.
Hi, this is Tamana Hook. I just want to say that was an excellent background. Well, one thing I did want to reiterate is that these are normal, healthy people with normal CBCs that would otherwise never see a hematologist. That would just sequence their blood and happen to find these mutations. So these are otherwise asymptomatic people. So it's very interesting.
Mm-hmm. And it looks like Dr. Addison is.
Yes.
Dr. Addison. Okay, good. We can hear you.
I think I finally got through the audio challenge.
Okay.
No, I agree that was an outstanding background. I think that really lays the foundation going forward.
All right, great. Okay. So the first thing that they did was they looked at these mutations in cohorts. So the first was prospective cohorts, and they newly sequenced the DNA for this study. And they were two different databases. The first is BioImage. It's gathered from patients with Humana insurance. They collected or they identified patients in Chicago and enrolled in Chicago and Fort Lauderdale over the course of 2008 to 2009. And in this, they were looking for patients, or really patients at risk of developing coronary artery disease. So they looked at older ages, and they had at least one risk factor, but hadn't actually developed CAD yet. And they worked hard to match the US Census race and ethnic demographics, but in this study, they only used European ancestry. And then the other cohort they used was the Malmo diet and cancer. This is from the early 90s, so they had much longer time to develop coronary artery disease or cancer or whatever they're looking for. And it was just residents of one city in Sweden. So the cases that they selected from these cohorts had, at some point after DNA collection, they had a heart attack or required a stent or bypass surgery, and the controls were just matched from that same cohort based on age, sex, diabetes, and smoking status. Then for statistics, they did COX-2 analysis and controlled for variables related to age, sex, cholesterol levels, hypertension, and smoking status. So first set of data. The overall percentage of CHIP for bioimage was 17% in cases versus 10% in controls, and in the MCD, 7% versus 4%. So overall, the actual number of CHIP was relatively low, but they were able to identify that it did increase, was associated with an increased risk of coronary artery disease. So the numbers here are presented a little differently than what I showed at the top. So it's the number of participants with coronary artery disease versus the total number at risk. So 94 of 326 with no mutation had CAD, 19 of 44 with the mutation, and that was 1.8 hazard ratio. And then for the other MDC, they had 21 out of 33 with the mutation had CAD. So overall, statistically significant 1.9 hazard ratio of CAD. And then they also categorized it by mutation. So the numbers you see are 300 and 600 total at risk with the bioimage and MDC. So what they did was actually included data from their previous paper, the 2014 paper, where they had analyzed the Jackson Heart Study, data from the Finland, United States study of genetics, and Framingham Heart Study. So they knew the baseline level of CHIP and if they had coronary artery disease. So this increased their ends, and they were able to, with this higher number, they were able to look at specific CHIP mutations. So the DNMT, they, for all the total, they did find a fixed meta-analysis of 1.7 hazard ratio. That was significant. The TET2 mutation, the p-value was greater than 0.05, but the ratio was 1.9. And again, we are looking at small numbers. This is 2 out of 6 in the MDC per se. The ASXL, twofold hazard or 2.0 hazard ratio. This was still statistically significant, including all 6 of the cohorts, 5 of the cohorts. And then JAK2, they had a really striking hazard ratio, but this is a total of 3 out of 5 people with the mutation had developed coronary artery disease. So it is striking, but it's a very small number. And then there's a whole slew of other mutations that also did show an increase in ratio, increased hazard ratio. So looking a little more granular. All right, so the next set of data that they looked at is they did retrospective studies. So not pre-developing, but people that already were enrolled at the time that they had an event. So this DNA is publicly available. The first is the atherosclerosis, thrombosis, and vascular biology cohort from Italy, collected 1998 to 2001, and looking at enrolled people that had a heart attack less than the age of 45 with age, sex, and geographically matched controls. And then they used the Pakistan risk of myocardial infarction study, or the PROMISE group. Started enrollment around 2009. I couldn't find the end enrollment though. And they did a first MI, regardless the ages enrolled was 30 to 50, and the controls that were recruited into this were hospital visitors or outpatients at the same time. So the cases they selected were early onset, MI less than 45 or 40 to 50, age match from the same study, and then they did logistic regression. And all of these had DNA collected at the time of the MI. All right. So this data. So this is a younger cohort. So as expected, we do see a much smaller percentage of people with the mutation. So 2% versus less than 1, 37.6 in the ATVB, and then in PROMISE 2% versus 1% of controls. But the odds ratios are pretty striking. For ATVB, 37 of the total number of people with the mutation had a myocardial infarction, so odds ratio of 5.4, and then 52 of all 65 with the mutation in the PROMISE study, a CHIP mutation had coronary event, so total of 3.4, so 4.0 odds ratio. And then they did look specifically at each mutation, not a statistical difference for the DNMT3A, but 12 out of 13 with TET was significant. Every ASXL and every JAK2 mutation was associated with a coronary with myocardial infarction, and then the majority of the others. So younger people with an MI were much more likely to have a CHIP mutation than other young people. The last thing they did looking at specific mutations was the percentage of total mutations, so the frequency overall of everything they identified. And just the x-axis is the proportion, or the y-axis is the proportion of total mutations, the x-axis is the actual mutations. And the percentages were pretty similar except for JAK2, which was much more frequent in the myocardial infarction younger cohort than in the older cohort. All right. And then the next set of data was uniquely available from the bioimage cohort. So everyone enrolled in this cohort got a coronary artery calcification score at the time of enrollment. So they looked to see how does that correlate with CHIP mutation. So on the x-axis, it's a log scale of their coronary artery calcium score, and then x-axis is their CHIP status and coronary heart disease status. So in patients without CAD, CHIP was associated with a threefold higher coronary artery calcium score, so 300 versus 92, and then almost double the score of patients with a CHIP mutation, 650 versus 300. And then the bottom panel here, they looked at variant allele fraction. So this is what percentage of the nucleated blood have the mutation. So a variant allele fraction of 0.1, as they indicate here, that was their line, means at least 20% of the blood cells have this mutation. So if it was this was very small numbers overall, but greater than 10% had a 12-fold higher risk or odds ratio of high coronary artery calcification, while there was no difference for the 11 total people with a smaller percentage. So very interesting, but not the numbers to really look at specific mutations, but the frequency does seem to play a role, kind of a dose response. All right, so that wraps up the cohort data. So if Dr. Addison or Dr. Hook have anything to add or comments on that, I'd appreciate their input.
First of all, I'll say, Dr. Campbell, that was outstanding. I think really one of the primary striking items that comes from this data is the accumulation of variant allele mutations. So as we saw with the panel B that you have displayed, in those who have a relatively higher burden of mutations, the actual odds of actually having excessive coronary calcium is extremely disproportionate as compared to those without. I think beyond that, I think the importance of the JAK2 mutation cannot be overstated. I think based on what we're seeing, although it's not highly prevalent, it does seem to be strongly associated with subsequent events. I think with that said, I'll let my outstanding hematology colleague have some input as well.
Hi, Courtney. Excellent job. I definitely echo Daniel's words here. I do think it is very interesting, although it is very small numbers, that the JAK2 was more highly correlated with coronary artery disease here. It is interesting to note that while JAK2 is considered a possible clonal hematopoiesis mutation that we can see in patients, it is clinically associated with myeloproliferative neoplasm. And of course, as we were talking about otherwise unselected healthy people without known hematologic disorders, it is possible that these are people that might have a different mechanism of having a hematologic disorder, including a predisposition for something like thrombosis that is often seen in NPNs. But again, this is very early, we don't know. It is also interesting to note that these different mutations, whether they're related to epigenetic modification or signaling pathways, might be associated with other outcomes or other risk factors for patients, such as smoking or other exposures like chemotherapy or radiation. So very interesting early data, and of course will spur further further research going forward.
Thank you both.
Yeah, I think that this is Dan. I was just there's a frequent confusing issue for me, and this topic is right on it, which is the, as you showed in these data, that the CHIP2 mutation frequently, or one of the most concerning, is a JAK2 mutation. And then the concern is that you may develop a myelodysplastic syndrome or potentially leukemia down the road. But I know with myeloproliferative neoplasms, they use JAK2 inhibitors as a treatment. And then the biggest or the most common cardiovascular side effect from those drugs are thrombosis. So obviously JAK2 has something to do with, thrombosis or atherosclerosis, as you point out here. What is the relationship between a myelodysplastic syndrome and a myeloproliferative neoplasm?
Oops.
That's a great question. So from what we know right now, myeloproliferative neoplasms, we really define them based on specific mutations or morphology in the bone marrow, and the same thing with myelodysplastic syndrome. So myelodysplastic syndromes are really defined by the dysplasia that we see in the bone marrow, along with cytogenetic and as well as molecular abnormalities like these mutations that we see here. Myeloproliferative neoplasms are usually categorized by either the BCR-ABL mutation or the ones that are not, such as the JAK2, CALR, and MPL mutations. Without those, we often have a conundrum of having an overlap type of syndrome, NPN or NPD, but also the clinical way that the patient presents also helps us. Usually with myelodysplastic syndromes, we see pancytopenias. With myeloproliferative diseases, we usually see, or we can see, very high white blood cell or red blood cell or platelet counts, often with splenomegaly and thrombosis as part of the presentation of the patient, or strokes or cardiovascular disease at presentation. So clinically, the patients present different, but really that the MPNs or the myeloproliferative really come with a very full marrow, very cellular marrow with specific recurrent genetic mutations. They may not have chromosome abnormalities. It's usually the chromosome abnormalities or molecular abnormalities that we really more see with the dysplasia. That being said, either way, you can go into a myelodysplastic or myelofibrotic type situation that can ultimately lead to acute myeloid leukemia, whichever way you present. So often there is that risk of overlap, but the way it's defined right now by the World Health Organization, it's by those specific mutations such as BCR-ABL, JAK2, CALR, MPL, with a morphologic and clinical presentation that would help us distinguish the two diseases.
Thank you.
And I'll add that that point was brought up. There was actually 3 or 4 correspondence back and forth published in the New England Journal, and they were able, at least in some of the cohorts, to say that these particular patients with the JAK2 mutation didn't have at the same time a known myeloproliferative disorder, and that their blood counts were, stable throughout that. So it wasn't that they had some undiagnosed, at least at the time, based on the data they had available.
Thank you, Courtney, for bringing that up. I will also say that there are many patients with AML-MDS that happen to have a JAK2 mutation, but they are not defined as MPNs because of the cytogenetic, morphologic, or otherwise the blast count that would give them a different diagnosis. So JAK2 can be seen in AML-MDS or CHIP, as we see here.
Great, thank you all. Okay, so I will go on to the more experimental, where they're trying to show a causation, and the authors chose to look specifically at TET2 for the set of experiments. And the way they did this is they did a bone marrow transplantation. So to replicate that it's a somatic acquired mutation only in the bone marrow, they bone marrow transplant from either wild type, a TET2 knockout, or TET2 heterozygous, which would be more consistent with what we might see in a person. And they transplanted into a atherosclerosis prone mouse, which had a knockout of the LDL receptor. And then they looked at various time points for the development of atherosclerosis. So they assessed the assessed the aortic root and the descending aorta. And important to note that the white blood cell count was the same in all of these particular mice, and there was no difference in the serum lipid level, so no gross changes. Right. So the results here, I'll start with A. These are aortic root sections at 5 weeks and 9 weeks with wild type on the top and knockout on the bottom. And really just looking at the gross sections, you can see this kind of pale blue area is representative of the atherosclerosis, and this area is much increased in the knockout mice, so the ones that have the TET2 negative bone marrow loss of function. They quantitate it in panel B. The lesion size is on the y-axis, and on the x-axis is their knockout status and age, and you do see they quantified an increase lesion size compared to the knockout compared to wild type at both time points that was statistically significant. On the bottom, looking at the gross pathology of the aortic atherosclerosis, the whole aorta is splayed out here. They used oil red O stain, which is going to stain the atherosclerotic accumulation. So wild type, you see very little of this red. Het, you see more grossly, and then in the knockout, you see quite a large amount of the red oil stain. So when D panel is quantifying the aorta pathology, so the percentage aorta affected is on the y-axis. So, just like 1 to 2% average in the wild type, and increase more of 6 to 7% in the het, and around the same with a much higher range in the knockout mouse. So these mice with the loss of TET just in the bone marrow cells have more atherosclerosis at younger time points. Oops. All right, so the next is they did an in vitro assay looking at the bone marrow macrophages. So they took bone marrow, just the macrophages from the wild type or TET knockout mice, and co-cultured them with the low density with LDL. They either used vehicle or LDL, wild type or mutant. So they have 4 different scenarios. They cultured these all together for 24 hours in a dish, and then they assessed the mRNA using RNA sequencing and looked at differences in expression. So first, this is just a Venn diagram. They looked at changes, differentially expressed mRNA genes by genotype, by LDL treatment, and then by both, and identified 217 that were different in both categories. Right. The bottom here now is a volcano plot looking at total difference knockout versus wild type percentage, and then at the bottom if it's a positive or negative change. So on the left is negative. They highlight genes that are associated with the lysosome as being kind of downregulated, and then they'd increase mRNA in the cytokine and cytokine receptor as well as focal adhesion. So that's in the red and blue respectively. And then the last part is they illustrated this in a different way. This is a heat map. So blue is representing downregulation of genes, red is representing upregulation. So on the left here, they have wild type with vehicle. All these genes are relatively down, decreased expression. The knockout and vehicle, you see a few red. This is the wild type macrophages with the LDL here. And on the far right, you see the knockout. TET knockout with LDL. So the top section you see higher fold expression of the chemokines and cytokines, inflammatory response related mRNAs, cell surface receptors, and then a slew of other genes. So all of these are just different ways of showing the same changes of what kind of genes are being expressed differently by these macrophages in the presence of cholesterol. So seeing that they saw an increase in the chemokine cytokine, they wanted to look and see if that actually was different in the mice, so not just a petri dish. So here are the chemokine levels. These don't translate directly to humans, but the mouse chemokine levels based on LDL knockout mice with various wild-type het or knockout TET, and these were assessed at 17 weeks. So almost all of these were significantly different and significantly increased in the mice with the TET knockout or heterozygous. And then in humans, they were able, in one cohort, they had this data from the PROMISE study, and they specifically looked in the no CAD group, I think based on numbers, and plasma interleukin 8. There was statistically significant difference in those with the TET mutation and not with a higher level. And then one last point that I thought was interesting that was buried in their supplemental data is inflammation related to the TET2 bone marrow deficiency, is that it wasn't just in the vasculature. They actually saw profound inflammation in all different organs, from the spleen, middle ear, kidney, lung, liver. Inflammation was everywhere. So before I go into the conclusions, I wanted to invite Dr. Addison and Hook to weigh in on this experimental data with the mice.
Thank you again, Courtney. This was very well done as far as really bringing home the translational aspect of these data. I think this underscores the potential that we have a true relationship that is from mutation to inflammatory/chemokine release and cytokine overexpression to the subsequent development of disease. I think this underscores the relationship that we in cardiology have begun to appreciate more and more over the last decade or so, which our cancer colleagues have seemingly captured, potentially even more so in the immunotherapy world, that really inflammation may be a key driver, and it starts really at the DNA level.
Yes, Courtney, great job. I echo Daniel's comments on that. This is really very interesting, novel, new data when this came out, showing that the inflammation response really was what was potentially driving these changes that we see. I did want to say that for the IL-8, like you mentioned, there isn't really a clear homology in mice compared to people. But it is important to note that all of these chemokines do reflect that the granulocytes really getting honed in on areas of inflammation, and it is very, very telling that so many different organs and tissues are affected by the inflammation that we see just by the single change of a potential just TET2, just an epigenetic regulator in blood cells.
All right, thank you guys. So just to wrap up, the conclusions from the authors based on this data is that the relationship between these CHIP mutations and coronary artery disease appear to be causal. These somatic mutations were significantly associated with both the development of coronary artery disease over time, as well as those with early onset myocardial infarction. And they did find a potential dose-response relationship between the variant allele fraction, the clone size, and the coronary artery calcium score. And then the loss of TET2 in their mouse model did accelerate the development of atherosclerosis. And with their last set of experiments, the CHIP mutation may alter the macrophage transcription, which increases the chemokines. And then at the bottom here, I have a figure that's from about a year later from the same group in a commentary about how this might look. So there's the mutation acquisition in the bone marrow. You do see an expansion of this population in the CHIP. It does maintain in the peripheral blood. And you do see this epigenetic alteration, particularly with TET2 and DMN, and a change ultimately in the cytokine chemokines. And this pro-inflammatory might be the mediators inducing more atherosclerosis. And then they did have some follow-up work that looking at JAK2 specifically related to potentially neutrophil extracellular activity, and that might increase the thrombotic risk. A few limitations I did want to point out. They only use European ancestry, so it does beg the question is if there's applies to other racial ethnic backgrounds, and if there's different percentages of these particular chips. I thought the dose response data with the coronary artery calcium score was pretty striking, but it is relatively limited. So it would be interesting, as I think Dr. Addison's pointed out earlier, how much this allele fraction counts and if that's something we should be paying attention to. They chose specifically to focus on TET2, but how do these other chip mutations potentially work? Is it through a similar mechanism? Is it something totally different? There is this widespread inflammation, and I don't know if it's entirely translatable to humans, but it is quite striking in the mouse models. But I don't know how much we really see that much in, an inner ear or something in people with high levels of atherosclerosis. And then, as was also alluded to earlier, this JAK2 is somewhat controversial, including in the chip with, there was letter to the editor particularly bringing it up, and they are considered sometimes initiating with polycythemia vera and essential thrombosis, these myeloproliferative disorders. So just a point that, like I said, has already been discussed. So I'll go into the post questions. So hopefully you all can answer these now. So the common mutations detected in clonal hematopoiesis of indeterminate potential affect genes and regulate hematopoietic cell transcription. That's what we're looking at. The proposed mechanism, as I think has been hammered home, is really increased inflammation overall. People found to have CHIP are most likely to develop a myelodysplastic syndrome. It's not linked to an acute leukemia or lymphoma. And then CHIP is detected in the blood using next-gen sequencing. So that's really allowed us to go into this. All right, so now I will open it up for Dr. Hooks to, I won't go through all these questions specifically, but to weigh in on how this evolved, since this publication, and how she uses CHIP in her current practice, and how does it change her care. And I'll cede the floor to you.
Yeah, I would say that, as a point of colloquialism, I guess, in St. Louis, we refer to the CHIP condition as ARCH, or age-related clonal hematopoiesis. And, it does so happen that the ARCH is in St. Louis. I don't know if that had anything to do with it, but I suspect it did. But so there is, as with many mutations and receptors and everything, they all have more than one name. So
Good to know.
So I think the main question that I would have is that how does this relate to cardio-oncology in real life? That's always one of the things, because the mutations that are detected are at a very low frequency, and they're in asymptomatic patients. So they're not patients that we're likely to encounter.
Right, absolutely. Thank you so much, Courtney. You did an excellent job, and thank you, Daniel, for the question. So right now, as you mentioned, these are not even patients. These are regular people, like you and me, walking down the street. We wouldn't know that we had something like this. So the first thing is that to recognize we don't routinely screen people right now. We don't know who has clonal hematopoiesis and who doesn't. And also, I don't use ARCH or CHIP. I just try to say clonal hematopoiesis, not to take sides. So the first step is that we need more research in this. So we need to establish programs, and there are centers and clinics being opened up where we're looking to study this specifically. And it would really be in that prevention of disease, prevention of future cancers, prevention of cardiovascular disease, et cetera, in that setting. But right now, the way we see it is, and in several situations, One is when a person gets a bone marrow biopsy for looking for something else. And then they happen, the hematologist that did the bone marrow biopsy happens to find a clonal hematopoiesis mutation that was done, but the patient does not have NDS or AML or anything like this. And then they are diagnosed with clonal hematopoiesis. Or it could be clonal cytopenia of undetermined significance. Like they might have a mild abnormality in their CBC. They are found to have these mutations, but they don't meet the criteria for full diagnosis of a myelodysplastic syndrome. So right now, all we do is monitor these people, watch their blood counts, and perhaps if there are changes to do serial bone marrow biopsies if there was a clinical concern for transformation, because we know that there's a risk of 1% risk per year of developing an MDS or an AML. The other thing that we're doing is referring these patients to our cardiology colleagues to see, because we know of this risk of increased atherosclerotic disease, in case there are any risk factors that need to be modified. This could be as bad as smoking, could be worse, we don't know. And so to be able to really early do risk reduction in these patients early, but there are no standards of care. And so this is where clinical trials really do come in. We need to establish what the risks are and also what we need to be doing for this population specifically. The other situation where we see this a lot are people that actually have AML or MDS. These are patients that they, like we talked about, the founding clones would be these clonal hematopoiesis clones, and then they develop another clone, a second hit, you can say, that then triggers their AML or MDS. They get treated with intensive chemotherapy, but then their DNMT3A, TET2, these clones can still persist. So these patients are in complete remission. They may have even gone through a bone marrow transplant, but they still have these clones. These patients tend to have a higher risk of relapse, depending on the clone. Some of them don't, because clonal hematopoiesis may not transform to an AML or MDS. However, these patients may also be at higher risk of atherosclerotic disease. We know that chemotherapy radiation already puts patients at risk. So do patients with clonal hematopoiesis then have a higher risk of adverse cardiac outcomes, for example? And if that's the case, do we need to change which chemotherapies that these patients end up getting? For we don't want them to get heart failure or something else down the line after they're in remission. So there are lots of questions right now. Right now, we're at that place where we're finding patients, but we don't know exactly what to do with them. We also, even in the transplant world, we don't know if these are patients that should go for transplant right away, because we know that they have worse outcomes, 5-year outcomes, overall survival. So, this is a place of active research for us. The other thing I did want to mention is that we do see variable allele frequencies. And of course, for clinical trials, we have cutoffs. Let's say at 20%, VAF is where patient would qualify for this treatment or that treatment or this trial or that trial. But we do find patients with lower variable allele frequencies of clonal hematopoiesis mutations that we just watch right now. And it could be when they relapse, that clone is the one that then grew out to become AML. So we see this, we know that it fluctuates, it changes, the microenvironment changes with chemotherapy, but how we treat these patients, we don't know. At least we can see it now, and we can understand why, for example, which patients relapse versus which don't. And also people with clonal hematopoiesis tend to have worse outcomes when they do develop AML or MDS, just from our experience. But again, larger trials are going to be needed to really establish the best care for these patients.
So I would be interested in your take on a couple of basic questions. So if you have an asymptomatic patient with no currently identified cardiac disease who's in their 60s, what is there any motivation to look for a CHIP mutation? Is there, in that particular patient, is there any reason to screen that population for a CHIP mutation? And then how expensive or how difficult is that to do?
Right, so there's certainly a cost associated with next generation sequencing, that's for sure. Just like how, if you wanted to screen a patient for a risk factors like atherosclerotic risk factor modification to check a lipid profile, there's a cost, but it's not that expensive. Next generation sequencing is quite expensive. in terms of who we might want to choose to screen, it would most likely be people, if they had no other risk factors, it would really be people that perhaps were considered at a higher cardiovascular risk factor. And it could be, for example, even a PSA test. You know, checking a man's PSA is not necessarily a standard of care, but it's often done to see if patients do have early prostate cancer. So there's a lot of what we do as screening, early detection, and it could be that next generation sequencing as the costs go down, but it will be a screening in the future. But for right now, without a strong indication, you know, insurances won't cover this, and that's why there's a big push for, you know, clinical trials to be able to really establish that. Because, you know, I will just say from the hematology perspective, once you're diagnosed with AML or NDS, it's really an abysmal prognosis, even with our best genetics. And so our goal really is to help prevent that from happening. And the same way, once you have heart failure, it's really hard to go back from that. And transplant is difficult for whether it's cardiac transplant or bone marrow transplant. And so, you know, we have to really look towards prevention of disease, and this is one step. It's really early screening. This isn't prevention, but hopefully this could be the step towards prevention. So right now, if you had a 60-year-old with no risk factors outside of a clinical trial, there really isn't going to be a place to do sequencing.
And then my other question would be, so we are definitely in the business of cancer survivors. So if somebody got treated X number of years ago and we are trying to be, you know, actively engaged in the management of their cardiovascular disease, whether they know about it or not, and we certainly want to be very aggressive about checking cardiovascular risk factors and managing those appropriately. Is there a role for next-gen sequencing in those patients that received drugs that make it more likely for them to have a hematologic malignancy in the future? So, you know, something, some sort of chemotherapy like anthracyclines or whatever that, you know, could have a secondary AML type picture.
Right. Absolutely. I absolutely would agree for this. And this would probably be one of our first cohorts of patients, hopefully that would be within, once we are able to really get this to be something outside of clinical research, to be something more broadly applicable. But it's very important for people that had intensive chemotherapy or even other cancer-related medications that could have, or radiation, you know, that could have secondary malignancy, hematologic malignancy down the line, to be screened early if there's a way to do some kind of risk factor modification. So there's just basically going to be at least a two-pronged approach, where you're going to have to be able to screen patients, be able to cost effectively do the next generation sequencing to identify which patients are perhaps at a higher risk of adverse cardiac outcomes after chemotherapy or cancer treatment. The second thing is we're going to have interventions for them. You know, it's not enough just to say, oh, you have a higher risk, but we need to be able to actively do something to help, you know, ameliorate that risk once we know that they have it. So that's why it's very important to develop programs and to really do the studies to see what we could do. But yes, I absolutely agree that once, you know, they had a life-threatening cancer, we had to treat them, and then down the road they're all going to end up with heart attacks. That's awful. You know, we need to do something, especially if it's iatrogenic. If we did something to them, what could we do to, you know, reduce that risk they have in the future?
Hey, Dan, of interest, Bonnie and I actually submitted a grant to study that exact question, and it got no traction whatsoever. But it's a great, it's a great idea.
Joe, you're just too far ahead of your time, buddy. You got to do it again. You know, Bonnie, I know, is one of the most determined persons I've ever met, so I'm sure she'll resubmit it.
But I think that this discussion just re-emphasizes the importance of inflammation and the fact that we probably, I think that LDL and the ejection fraction have blunted a lot of things that we should be doing. So I think it's another point that we should be much more actively looking at inflammation and trying to reduce it, as well as reducing LDL.
Yeah, I mean, I think that anybody who, for example, sort of based on the paper that you presented, Courtney, I would say certainly anybody who had a CHIP mutation, I would absolutely put them on an aspirin and a statin, regardless of what their whatever their cholesterol is, but especially if their CAC score was a little high or any of those things. But so I think that this could be an area that we would actually prevent disease. And so, that's always desirable. If we can prevent something as opposed to dealing with a complication, I think we're always going to be ahead of the game. But especially in the cancer survivor group, we know that their cardiac outcomes are worse than age-matched controls, et cetera. And then, of course, they're at risk for secondary hematologic malignancies if they got, significant chemotherapy. And so I think, CHIP may be, a CHIP mutations may be a very important window into prevention. And I think, that to me is a super important area for further investigation.
Yeah, I thank you so much, everyone. This has been it's a fantastic discussion so far. I agree. It seems like CHIP would be a really good window and a really good way to identify, especially patients in the hematologic malignancies that would benefit from seeing cardio-oncology early, because it's always a question of, what patients are we wanting to aggressively watch and keep a close eye on. And I think this is likely a cohort that we're missing, independent of all the other risk factors that were controlled for in this study. This was CHIP mutations were enough. So I want to make sure Dr. Addison has a chance to talk a little more. So for my questions on the cardio-oncologist side of how much are you seeing CHIP mutations and how is that changing your approach generally? Should these be triggers if they don't have a coronary CT to get one, to do stresses more frequently? And then do we think that lipid management is going to be enough? Or do you think this inflammation is maybe even beyond just cholesterol levels? And I know one big plus of the statins is that they do tend to be anti-inflammatory and not just cholesterol lowering. So Dr. Addison, do you have any, let you weigh in your thoughts?
No, thank you again, Courtney, and thank you all. I think a lot of the thoughts have already been generally echoed, but I think to be a little bit more precise to answer this, I think most of us are relatively infrequently seeing CHIP mutations within patients. I think really developing the most optimal strategy to manage them as a heterogeneous target. Generally, most of us, I think, would think about putting these patients on aspirin and finding some reason to at least put them on a statin in some form. I do think that if there's any concern like family history or something else that you could actually put on paper to document, I think it's very appropriate to consider coronary calcium score CTs in these patients. And that is something that Tamana and I have actually discussed many times as well. I think as far as stress testing right now within the realm of cardiology practice and actual established evidence, there's not really validity to really sending these patients for overt upfront stress testing, nor do we know that the actual disease they may have would actually be functional if we just did a stress test. I think for that reason, the coronary calcium score CT really might be a golden ticket here. And I think that's what the authors of the study actually started to understand. I think beyond that, as far as aggressive lipid management, I do think that that is something that has a basis in any patient, but almost more so in the CHIP setting. And then I think really finding novel ways to actually translate some of these findings into actual clinical care through relatively kind of combined or even adaptive studies, specifically with our hematology colleagues, are really the next step. There's a clear signal here that targeting inflammation may be a key, I think many of us in the cardio-oncology sphere and beyond are beginning more and more to understand that. And I truly believe that that's really the next frontier. So I would generally say that, right now, CHIP is still relatively in its infancy. I think it's a little bit more advanced in the hematology sphere, but I think the combined efforts can really bring this forward. Lastly, I'll also add that you made a great point that the populations for which this was studied were not necessarily fully representative. And I think even beyond that, there's a huge proportion of patients who develop atherosclerotic events who did not have these mutations, which again speaks to this idea that there's probably something more. So I think further investigation even on that front would be really our best bet here.
All right. Well, you guys raised the bar. Very nice presentation. We appreciate it, and we greatly appreciate the cardiology and hematology expert opinion. I think that's what we need to do. So thank you so much for organizing it, and presentation was excellent. And we'll say that this is the bar now. So people are going to have to get over this bar.
Thanks, Dan, and thank you all. This has been a fantastic discussion. I learned a lot just about CHIP in general, because the buzzword that hadn't really been explored much on the cardiology side. So thank you so much for this opportunity, and thank you, Dan and Tamana, for all your insights. This was fantastic.
So the only other piece is that you need to start thinking that it's called ARCH.
ARCH. ARCH, clonal hematopoiesis, to toe the line and not upset anyone.
That's all right. No, thank you so much, you guys. It was really quite fantastic. So we appreciate it.
Thanks. All
right.
All right. Steve, you got any updates for next week?
Next week will be our regular case review, and I think I already sent out an email with a description of that. I can't remember what the topic is offhand since we're doing these weekly now, but next week, same time. Yeah, trastuzumab. You're right.
Yeah.
Right.
All right. Great. Because there were questions, there's CME credit, so that's something you can look into.
That is really fantastic, and we will save some of these questions for our board review manual that we're preparing. Those look like really good questions, and that way people who actually watch the webinar will get an early insight into what the questions will be.
Great. All right. Thank you all. Look forward to next week.
All right. Thank you.
Thank you, Courtney.
Thank you.